Okay, thank you. So this presentation is mainly going to focus on the impact evaluation of the heart failure targeted funding programme that took place in 2023-2024. So the main areas we're going to focus on are the background, the priority areas of the project, the scope of the evaluation, how the data was collected, and the metrics that were involved, and then the methodology followed by the results and reflection. So in terms of background, the NHS long-term plan highlights the importance of better care for people with cardiovascular disease, and access to specialist care for heart failure is recommended by NICE. And NICOR, which is the National Institute for Cardiovascular Outcomes Research, produces an audit which states that access to a cardiology ward or specialist care helps to improve patient outcomes, mainly lower mortality in hospital and out of hospital. And this targeted funding programme was developed by NHS England's Clinical Policy Unit, and it provided non-recurrent, which means 1 year of targeted funding of over 4.6 million to help improve access to heart failure specialists, and also access to the specialist multidisciplinary team in a community setting and during admission. The aim of the programme was to support local systems to help them deliver the long-term plan and broader cardiac transformation programme outcomes, which was to reduce heart failure 30-day readmissions rate. So in terms of the priority areas of the funding programme, in 2021, 15 cardiac networks across England were established to support high quality and integrated cardiac services. And NHS England asked these networks to coordinate proposals and to set out which of the 3 priority areas they would focus on in terms of the funding that they would receive. So in terms of the priorities, the first priority was early detection of heart failure in a community setting, which involves enabling the development of community heart failure pathways and specialist triage to improve diagnosis and management. The second priority was early diagnosis and treatment during admissions with specialist input and robust discharge planning. So that would involve timely access to appropriate investigation, including NP testing and echocardiography. Also to ensure that in patients either new or existing, either with a new or existing heart failure diagnosis, are seen and treated early by a specialist team and relevant members of the multidisciplinary team. In terms of the third priority area, this was to provide early specialist follow-up within the communities, so to improve discharge planning and continuity of care, to optimise patients and to reduce the risk of readmissions. So by integrating acute and community services and improving follow-up, as well as patient education and self-management, and also to ensure that people with heart failure are cared for by a specialist multidisciplinary team led by a specialist, and also given a single point of contact. And access should also be offered in hospitals and community settings. So in terms of the scope of the quantitative evaluation, the strategy unit was commissioned by NHS England to evaluate this targeted funding programme, and all agreed proposals were reviewed by the evaluation team, and 63 funded projects were identified across the 15 networks. So most heart failure services already collect specific heart failure data, and this is submitted to the National Heart Failure Audit, and the evaluation team worked with the Heart Failure Steering Group, NHS England and NICOR, to identify subset of the data to create a minimum data set for the impact analysis. And alongside this minimum data set, some additional bespoke metrics were created to help determine the impact of the funding. So in terms of the qualitative aspect of the evaluation, this mainly focused on exploring a sample of the projects as case studies in more depth. So the 4 project themes that were identified by the Heart Failure Steering Group included introduction to the use of digital tools for heart failure services. So that's what Luton and Bedfordshire mainly focused on, and we'll come to them later. Also to enhance community detection of heart failure and to provide patient education, as well as rapid up titration of heart failure medications, so which involves ensuring patients are on the right balance of treatment. And there were 3 other projects which couldn't be grouped into those 4 themes, but they focused on rapid in-hospital heart failure diagnosis, auditing heart failure patient pathways, and building heart failure capacity. So that was mainly the focus of the South East Hospital Trust project. So in terms of the data collection period, the collection period was for 12 months before the start of the project. So that was the baseline period, and this ran up until August 2024 to fit with evaluation reporting timelines. And the baseline data was obtained directly from projects alongside the post-intervention data. So this graph shows the number of projects that started in each month, and this runs from September 23 to January 2025. So as you can see that we could only include projects up to August 2024. So it gives you an indication of how many projects are started by then and the proportion that had to be excluded. And following discussions with NICOR, it was established that based on our reporting timelines, we would be able to use their data directly. So we asked these project sites directly to provide the data to us for this evaluation. So in terms of data collection, there were 63 projects that were reviewed by the evaluation team across 15 networks. 8 projects confirmed that they couldn't proceed because the funding was redistributed to other areas. So that left 55 confirmed projects. And from that, data wasn't requested from some projects because they weren't expecting to impact the metrics in the minimum data set, or they couldn't provide the data within the time frame required. So that left 36 projects that we asked data from. And of those 36 projects, only 16 provided data, and only 14 projects provided enough baseline data for this impact evaluation. So in terms of the metrics, there were 14 metrics in the minimum data set. And these mainly can be divided into metrics which focused on improving access to a particular type of staff member, as well as improving access to particular types of treatment, either during their admissions or during follow-up. And each project was only asked for metrics that were relevant to them, so not all metrics were requested from all projects. And these were also analysed in different ways depending on how many projects provided results. So where enough projects reported on a particular metric, a national level meta-analysis was undertaken, and where insufficient sites provided data, then only site level analysis was provided for them. And similarly here with the additional metrics 9 to 14, we took a similar approach in terms of how they were analysed. Also, some bespoke metrics were collected outside the minimum data set. So these were around emergency heart failure admissions, length of stay, and readmissions within 28 days. So these were only requested from one project each, and a site level analysis was undertaken for them.
Cool. So I think I'm going to try and talk a little bit about the methodology that we use to try and determine impact here. So just at a high level, essentially we're trying to determine impact at 2 different levels. So firstly, we want to know the impact of receiving loads of funding for individual sites that receive funding, like per site essentially. And then also we're interested in, like, nationally across all of them, if we add it all up, what is the impact across the whole funding program. So the way that we did this is that we essentially did a 2-stage process where we estimated the impact of each individual site and then aggregated and then added up all the impacts. As we're going to come on to, the big question here is, how do you add up essentially the uncertainty for each individual site when you add that up to make the national estimates. So first, let's talk about the methodology for each individual site. So the kind of key thing here, right, is that we don't have any data from any control sites, right? So that really limits the actual, like, available methodologies that you have to do. So we don't have, so basically you just have an interrupted time series. That's fundamentally the only methodology that works with just kind of pre and post data. So essentially the idea of the ITS method that we used is, it was a package called Causal Impact, and how that works, it models the trend in the pre-intervention period for each individual sites and projects that trend forward into the post-intervention period. And that's essentially a prediction of what would have happened just based on the pre-intervention trend. So it doesn't include information about the intervention. You can then compare that projection to the actual post-intervention data, and the difference is essentially an estimate of the impact of the intervention, which in this case is the additional funding. So this kind of method is quite good at dealing with kind of random fluctuations up and down that happen month to month, and it's actually super good at if you have systematic seasonal variation. So it can account for, let's say the number of referral goes up every December or whatever it is. And the big thing is in some ways it's not so much about the projection that it makes, it's about how calibrating it's how good that prediction is. So it's able to calibrate the uncertainty around that prediction based on how good it is at predicting in the pre-intervention period. So essentially, if it's really good at modeling the pre-intervention period, then it'll be fairly confident about what the post-intervention period is, whereas, and vice versa. Yeah. Oh, yeah. So this process is kind of automated, and then so we run this separately for each individual outcome for each individual site that we had data for. It was actually done super efficiently. Yeah, Faizan did all of that work. I think we've got loads of great code we can copy and paste for similar things in the future. This is an example of what that would look like. This is simulated data, so like the outcome looks a lot neater than any of the real data. But essentially, so you have the green vertical line is where the intervention happened, and to the left of it you have the pre-intervention period. So the black line is the actual outcome of the data, and the grey dashed line is our prediction. So as you can see, sometimes the prediction overestimates, sometimes it overestimates, sometimes it underestimates. But broadly, it's actually the prediction is always within the blue kind of uncertainty range. And then you can see what it's predicting to do in the post period. The prediction here you can see is actually not doing anything sophisticated. It's just drawing a line. The model doesn't always do that, but sometimes that is the most efficient way of projecting forward. But the crucial thing that I think to focus on is that the blue uncertainty range is increasing over time, which kind of makes sense, right? If you have two years of data, predicting what will happen tomorrow is not as hard as predicting what will happen in 3 years' time. And as you can see, so in this simulated data set, right, you can see that the actual outcome increases by much more and is sort of outside of the range of the pre-intervention period. So there was an effect in this fictional scenario. Okay, so before we move on to how we add this all up, I think let's think about the limitations of this as a method. So firstly, I think the method kind of underestimates the true amount of uncertainty, or at least gives a misleading sense of how much uncertainty there is for a few reasons. So firstly, we kind of use the default version of this, which is that it doesn't account for secular trends over time. So it deals reasonably well with if things randomly go up 1 month and randomly go down. But if there's some kind of long-term trends, like say you've got whatever it is, an aging population, or all these other kind of things that are going to cause systematic changes month on month, this methodology doesn't really work. There are ways of amending the method to work for that, but they just increase the uncertainty, like by an order of magnitude. The other thing is we used again the default version of this package, which kind of just assumes that you have normally distributed errors. For nearly all of the outcomes, the outcome that we're interested was like change as measured in percentage points. Now, percentages obviously not necessarily normally distributed, and you're going to have points where a percentage is near 100% or near 0%, where its errors can't be randomly distributed because you can't have negative 10%, for example, right? So, I mean, we kind of did an eyeball test, and there were a couple of sites where we basically had to exclude them from analysis because the data was too, it was too, you had 0, 0, 1, 0, 0, or whatever it is. So this method would have performed really badly. But even excluding those, I think we should, this method should give an incorrect estimate of the uncertainty. And then it's an observational method, right? Like you just can't get away from the fact that there could be other stuff going on that just happened to be timed at the same period, which would therefore make it look like it was our intervention, but it could just be something else happened around that time. This is essentially just omitted variable bias, but it is like a particular risk with ITS, I would say. So even given that we're not accounting for all these types of uncertainty, and there's actually other things I haven't mentioned, a bit more technical and probably potentially less important, but this method still has quite a lot of uncertainty as a methodology because, well, basically it's trying to make predictions about the future using only the past, which is just a really hard problem. That is just, I'm sure anyone that's worked with time series, we all know that's just generally that's super difficult. And it's particularly difficult because we only had quite a small amount of pre-intervention time periods. There was some talk of whether we could get more than 1 year of baseline data, but it wasn't really viable in the time frame, and for kind of various reasons. And then also lots of the outcomes that we're interested in just had kind of small numbers. So once you get down to a particular project, the number of people they're seeing, particularly when they're broken down by month, might actually not be that many people. And that means you get a lot of volatility, right? If you've only got 5 people some outcome can go from 100% of people left with a discharge management plan to 20%. I mean, I actually think 5 people is probably lower than we had, but it was still much lower than we'd want for this kind of approach. Yeah, so that led to lots of volatility in the outcome. The other thing to remember is we've got loads of sites and loads of outcomes. So we should be expecting, a reasonable number of false positives, just because of like that's how statistics works. Even if the intervention's done nothing, we should be expecting false positives because we've done so many tests. There are methods to account for that. If you wanted to, we didn't do that. I'll talk a little bit about that later. Okay, so that's all the problems that we've got just at estimating the impact at the individual level. Now let's get to adding it all up, because in lots of ways, this is where I was more excited. There's all this uncertainty for each individual site. Maybe we shouldn't trust that, but hopefully when you add it all up, we can get something more meaningful about the effect overall. So how are we going to add it up? So the approach we took is something we've done on a few projects, was where we just aggregated it using meta-analysis, essentially. So we grouped all of the results by outcome. So all of the sites that had data on a given outcome. And then, so meta-analysis uses this process called inverse variance weighting. So it's a random effects model, which assumes that essentially the impact of the intervention is going to be different at every site, but there's a kind of distribution of effects. So there's still an average. So across all the sites, there'll be like an average effect that the intervention has, and there'll be some plus or minus on that. So some sites, it could be that on average the intervention causes a good outcome, but there was one site where genuinely it made things worse, or it had no impact, whatever, right? And crucially, we can estimate the shape of that distribution, and the core thing is the mean of the distribution, the average effect, based on, well, one first thing is how much our estimates of impact vary between different sites. But also we want to account for the fact that some of these estimates are really uncertain. So they could look really weird, not because they're genuinely reflecting something weird, but just because there wasn't that much data there. So what the meta-analysis process is doing is weighting more precise estimates more highly than the imprecise estimates. Again, this was implemented using the meta package. This is the first time we've used meta in this, but this was implemented using the meta package, which is super nice to use. Actually, I think very, very intuitive and kind of straightforward. So again, let's think about the limitations. Let's play the same game again at the level of aggregated outcomes. So I think the method gives kind of a misleading sense of the uncertainty, because there was loads of missing data, right? We were super reliant on the sites to submit data. Lots of sites didn't submit data for all outcomes. Even if they did, in some cases it was too patchy, the data they submitted, so we couldn't use it. The method actually can account to some degree for missing data in quite a kind of elegant maximum likelihood sense, but that you can't do that much if you've got, like, if most of your pre-intervention data is missing, then there's only so much your fancy statistics can do. And also this missing data is super non-random, right? We would expect that there's all different kinds of mechanisms that could cause that might affect both the outcome and also affect whether or not they submitted data to us. So that's like a big concern. Again, we have the same issue about the normally distributed errors. Arguably less of a concern here, but nevertheless, this can still cause issues as well. And so I think it's worth coming back to the point I made about the estimation of the precision, right? Because the precision is being weighted really highly here. And so what the method is doing is assuming there's, like, if you had an infinite distribution, what would the average of that be, and what would the variance be? But in some sense, what we don't actually want that, right? Because we want even sites that had a really volatile impact to be counted equally as the places that had a less volatile impact, right? So essentially what this is doing is more heavily weighting sites that, for example, had more post-intervention data, or they affected a larger number of people, or they had less volatile trends. This is going to cause problems. Let's say this intervention, receiving additional funding, works really well if you're a small organization and that funding is in relative terms quite a lot of money. That means, so small sites that are super volatile, it has a big effect, but large sites that are less volatile, it has a smaller effect. This method is going to be biased towards the larger sites where it has a smaller effect, so we're going to get a biased estimate of the kind of total impact, even though it's doing something that, relative to the average of some hypothetical infinite distribution, blah blah blah, is doing something reasonable. And then finally, something that, like, is kind of I don't know, arguably like philosophical, but like, the idea is this is calculating the average of some distribution, and we can ask, is that distribution like actually meaningful? Just because we've grouped together all these numbers, are they actually interpretable to us as a meaningful thing? And all the interventions are actually doing something slightly different with the money. They've all been operating for a slightly different amount of time, and also we're testing them after they've been running for a different amount of time. So some of them might have only been running for 3 months, some of them have been running for 12 months, or that's the amount of data they've given us at least. And we're kind of just adding these all up, essentially, or calculating the average of all of those. And mathematically, that's like not a problem. You can do that. But the question is, when I go to interpret that, what does that mean, right? We've got the average of 3 months of this type of intervention and 12 months of this type of intervention. Yeah, but that's the data we had. So let's talk about the results. So we've got all this uncertainty which we're not actually accounting for. I'm just going to show the kind of the best estimate of the average change and then the 95% confidence interval. So we've got the 4 outcomes that we're doing the national analysis for, and these are the results. So first thing to notice is that all of them are non-significant. None of them are statistically significant. But also the range is just massive, right? So this is as measured in percentage points. And so let's look at the first one, participation seen by specialist clinical staff. In this case, it could have caused a 10 percentage point increase in the outcome, which would actually be great. That's that would basically be a massive success. Or it could have caused a minus 15%, or it could have caused a 15% decrease, which is obviously dreadful. Any decrease is dreadful given that we gave them extra funding. And if you look at all of them, that there's just so much uncertainty that I mean, I could have given you a smaller range than this before we analyzed anything, right? Like I'm pretty confident that giving all these sites extra funding didn't cause a 15 percentage point reduction in people being seen by clinical staff. And that's I don't know. Yeah, that's not based on any statistics, right? Yeah, so I'm now going to hand over back over to Faizan, who's going to talk a little bit more about the individual level analyses that we did.
Okay, so for the individual sites where there wasn't enough data to do a national level meta-analysis, individual sites were analysed separately. So the first case study project took place at South Tees Hospital, and prior to the funding programme, the heart failure specialist nurse team were responsible for holding community-based clinics for education, medical titration, supporting early diagnosis, and running an outpatient IV furosemide lounge. And the aim of this project was to increase the capacity of the specialist nurse team so they could help meet the increased demand, which was mainly driven by an aging population as well as increased obesity rates. And the reported benefits from the qualitative side was that the outpatient lounge reduced anxiety around hospital-acquired infections and also avoiding hospital admissions. And these benefits were particularly valued by elderly and palliative care patients and their families. So in terms of the results, for the IV furosemide clinic, this was metric 11, and it showed that there was a statistically significant increase of 4.5 patients per month, and the 95% confidence interval shows that the true range was from 1.6 to 7.6 patients per month. So although this was a positive result, it's still with a small increase compared to what was happening previously, but it's quite targeted and focused in one area. In terms of the second metric, this was admitted heart failure patients that were entered into the NICOR audit. So there was, again, a statistically significant increase of 3.9 patients being added to the audit per month, and that 95% confidence interval ranges from 0.61 patients to 7.4. So in terms of the second case study project, this took place at Luton and Bedfordshire. So this project identified the need to improve discharge planning for heart failure patients in the Luton and Bedfordshire area. And they mainly aimed to do this by improving early discharge care and enhancing the use of a remote monitoring system called Doppler to help reduce the risk of hospital readmission. So the funding programme was used to secure staff capacity to support, standardise and integrate the use of Doppler to monitor heart failure patients in the community, and also to deliver other activities to support post-discharge care. So the impact evaluation found that the project may have had a negative impact on their metrics, but this could be related to the challenges that were reported by project stakeholders. So these findings are from the qualitative side, and they found that patient engagement with some patients was quite difficult because they found monitoring to be quite anxiety provoking, and also remote monitoring could have reduced the need for patients to be seen face to face by the community heart failure team. So in terms of the results at the Bedfordshire Community Health Services site, this was a significant result, but it was negative, and it shows for metric 3, which was the patients seen by the community heart failure team, there was a statistically significant decrease of 57 patients per month, and that could be anywhere between 99 to 17 patients reduced in terms of being seen by the community heart failure team, which obviously isn't a good result or something we'd like to see, but there were conflicting reasons why these results were produced. And similarly with the uptitration at the Bedfordshire site, this was also a negative result. And although this was significant as well, and it conflicts with the original, it conflicts with the qualitative findings, but it shows that patients that were uptitrated by 90 days follow-up was metric 10, and there was a statistically significant decrease by 4.9 percentage points, and the 95% confidence interval ranges from 6.7 to 3.1 percentage points per month. In terms of bespoke metrics, only one of those was significant, and this was at the project at the Yeovil District Hospital. So in terms of emergency heart failure admissions, which was metric 15, this is a metric that we would like to see decrease. So this was a good result to see that the best estimate was that the funding programme caused a reduction of 32 patients per month, and that ranged from either a reduction of 16 to a reduction of 48 based on the 95% confidence intervals. In terms of the reflections of the project, the broad story here is that even using these methods, which were probably overconfident, the results were really uninformative, particularly on things like impact on participation, which was between 15 percentage points decrease or a 11 percentage point increase.
Yeah, I think the other thing that I want to get across is I've really kind of hammered us on the methods here, right? I spent a long time talking about all the limitations in different ways. That said, I do basically think this was the best analysis we could have done, given what we knew at the time and the available constraints. Like we didn't go in knowing all the different types of data that wouldn't be available. So yeah.
Yeah, similarly, knowing what we know now, we would probably have designed a different kind of analysis, but relevant information wasn't available, such as the lack of data from control sites, missing data from sites, not just sites, but for metrics as well, and also small numbers which would have to be suppressed.
I do think there's a few things that we would change, and I think the one thing is that so going into it, we did say that we'd try and have the outcomes be related to the specific goals of individual projects, but I think we really could have hammered that a lot harder, and in the end, we ended up having kind of too many metrics being estimated against too many sites, which meant that when we were reporting them individually, you end up having results that some results do make sense, right? Like as Faizan talked about earlier, some of them aligned with the goals of the project in quite a clear way. But you also had sites where the outcome basically bore no relation to what the qual team said they were doing and what the intervention they were actually intervening was. And so in that case, it becomes, I mean, how do I interpret the case where it doesn't make sense? And it also means how do I interpret the case where it does make sense, right? Like, how do I know that's not also just kind of a random false positive? So yeah, I think going forward, really going to try and be a lot like stricter, even though I think often clients want you to let's just answer all the questions for everybody. And I think it's really important that we try as hard as we can to push against that. Yeah, I mean, there's also another thing about the exact method of the ITS, which, we did this analysis a while ago, and I think we're trying to move away from using it in the way that we did here. But again, we actually don't really have that many options in this situation, so it's difficult to know what to do. And then something which I think we kind of came through here, given the amount of uncertainty, and happens all the time on all of our evaluations, is 1 year is just a very short amount of time to see impact, because we don't even have 1 year of data, and also the intervention didn't start on day one. They, if they receive the funding on day one, it's going to take a while to fill the posts, get all, whatever they're doing. Yeah, so again, it's too, especially if you're interested in the level of individual sites. But yeah, that's everything from us. Do people have any questions?
Thanks very much, both. That's a really interesting walk through your approach to this evaluation, which sounds tricky because you're working with data from so many different places, variable, I suppose, quality, and all the other things which go with data from different settings. So there's one question on Menti which I'll just which is actually the same as what I've just written down. So it must be an excellent question. So the one I won't share my screen. If you're logged in, you'll see it. But it's basically, have you fed back to the client to suggest that provision of suitable evaluation data should be condition of funding? So there's a lot here, isn't there? There's this the relationship with the client who's obviously paying for this evaluation. Evaluations are very, very important because we need to know that public money is being spent well. We need to know that we want to genuinely know that the interventions are working or not, which are working well, and which ones should be focused on, rolled out, and so on. So this is it's really important, that relationship, but feeding back to the client to suggest that provision of suitable evaluation data should be a condition. So how do you respond to that?
In the report, and as well as the steering group meetings that we have with the client, we have stressed the importance of having robust and clear data that we can use for the analysis. And I think going forward, there are different ways of, I suppose, getting around this issue, and I think one of them would be to sort of provide them with the analysis or the code so that they can run things when more data does become available. And I think if it was possible, then I think it'd be important to stress. I'm not sure if we could make it conditional upon doing the impact evaluation and the funding to stress that the data is required, but I think they understand if we had better data, then we could provide clearer answers. And I think that should be enough to sort of perhaps get the message across in terms of what we can present and show.
I also think one thing is just doing it later, like, because we probably could have got the whatever it is, the audit data, a clean version of the audit data, if it had just if there'd just been a longer gap between what we were evaluating and when we evaluated it. So I think that was talked about in the steering group meetings. But the other thing is just like, in lots of ways, the type of evaluation where you do it super quickly and you don't exactly know what data you're going to do, what data you're going to have access to. That's actually fine for the qualitative team, and the qualitative team can get loads of really useful stuff in that context. It's just, I think the difficulty is sometimes, putting them together, the actual context of what is needed for a good quant impact evaluation and what is needed for a good qual evaluation don't necessarily go together. So this is actually a great context for all the qual work to be done. It's really early. There's enough time for them to feed into future rounds or whatever, being like, oh, these type of issues came up. This is the type of setup that alleviated that type, whatever. So I think that's another challenge.
That's really interesting, and I think this comes up time and time again, and I think we've had different experiences of that in the strategy unit as well when we've been doing evaluations, that the timing of an evaluation is much more suited. So the proximity of the sort of being requested to do the evaluation in relation to the actual project when it's finished and so on. And like you say, they're different sizes, they were doing different things, which is both the beauty of it, the sort of the complexity of it as well. And it's its strength because you're covering different approaches and the qual can pick up on that. But it's also very difficult to aggregate, to get solid answers from. And of course, they want numbers. People want numbers so they can demonstrate that this actually worked. This is something that we want to invest more in. We invested well in this. We did a great job.
Totally.
People, you want that positive feedback, and of course, you were on an aggregated basis. You weren't able to give that to them. And I just one of my questions was how did the client sort of respond or react to the fact that the bottom line figures didn't really sit well with, I imagine, their hypothesis and what they would have liked to have seen?
In terms of their response, I think the clients understood that what we could show was limited based on how the data was collected. And I think they also knew that even if all the data was in place, it would be, I suppose, difficult to show impact quite early. So I know for the quant side of things, probably wait until later would be probably a better approach to take in future.
Yeah, I mean, I think we kind of told them as we were going along, so that meant, it's not like they got a surprise at the end where they got
sure.
And the other thing that I think helped us is there was a really rich, good qualitative report that had loads of detail and useful stuff in there. I imagine if this had just been a quant report and we'd written impact plus or minus 10,000, that would have been a very different conversation than
and it's that's a difficult space to be in, and I've been in an almost identical project, and I've been doing the quant analysis almost identically, in that it was too close to the end of the project, it was too variable, and there wasn't enough data. You want to please the client by doing a really robust analysis with and doing it all in the right way and everything. But had it not been for the qual side of it, which was really thorough, it gave a really rich understanding and much more information that could be used sort of going forward at that time. It would have been, I'd have even sat there going, oh my goodness, this doesn't feel complete, and it often isn't. And I think this comes back to yes, there's lots of things about the timing of an analysis, and for it to, the right data, and maybe having the some better way of getting the projects to disseminate, to give that data to you, so that, some sort of direction which wouldn't have come from you, would have come from the client, to sort of set the scene so that happened more easily and you got more data. But there is also I forgot what I was going to say. What was I going to say? Andre, what was I going to say? Come on, give me a clue. Well, my tummy's rumbling. No, you can't go yet. No, I think there was something else I was going to say, which was about, this isn't it. I'll come back to it, but I was going to say something that you picked up on. This sort of, and it's covered some of these things anyway. It's like that pushback to the client in terms of, I know you have you've spec'd this out. You want answers to all these questions, and we want to give you answers to all these questions. However, I want to push back because it's too much information. There's too much detail. I'm going down into all this detail because this is what you want, and the numbers are disappearing, and so on, and the metrics aren't they're disappearing because some of the trusts are, it isn't relevant to that trust or that project, that pilot. So it's that kind of the importance of getting the question right, and it's just like that really important bit at the beginning, which is hard when it's a paying client, but we do it as part as routinely as part of the processes that we follow. But it's so important to get, I think you'll agree, to get that initial question right. And therefore you can structure your response and and solve the problem with the right techniques. But it seems like there was a sequence there which was kind of missing. They might sort of got the question right. It might have been too detailed. You said you could say I can answer that question, but you didn't know what the data was going to look like at that point, did you?
Yeah, I think the big challenge as well with that thing is that some of the in essence, the reason why it's so bad asking so many questions is actually kind of like technical statistics. I don't know, like intuitively, it does just seem like, well, we've got data on all the sites. Tell me about all the outcomes for all the sites. What's wrong with that? And then, but obviously, you don't want to have like a long conversation where you try and explain about false discovery rates or whatever. And whatever, this is actually going to reduce the power of blah blah blah. Yeah, so I don't know. That's quite a difficult thing to manage where. You have to say, for technical reasons we're not going to get into, we don't want to answer as many questions as we have data on, which I think that's difficult to kind of negotiate.
Yeah, I think there's
sorry, Faizan.
I think there's like a sort of slight bias towards, well, if we ask as many questions as possible, then we get as many positive results as possible. That's not how it works. And I think sort of getting that across to a client at the start would be kind of it would help to like focus the questions on a few key areas that they're sort of focusing on rather than trying to measure everything.
Absolutely, and I think sort of we learn from this. They learn from this. They learn to what to expect, and maybe the timing of the evaluation when they're in their bigger programs. They can say, well, it makes more sense to do the evaluation bit more delayed, and so that hopefully they will learn from this as well. So and have they learned from this in terms of sort of taking this forward? What will they do with the results? Is this kind of like you did the report and it's back to them, and you don't know, or do you know what happens next with this? All your hard work.
I think it's a bit of an open question as to what they take forward, but I think the results and findings and they'll take on board, and the full set of data will actually be available around about July time. So it could be possible that they may want to do a more in-depth or rerun the analysis on like the full set of data. So it's possible that they could get more kind of robust findings that way, but I don't think anything's been definitively agreed on anything really.
Okay.
I think the challenge is also that when the full data is available, they can do methods that are more robust than this, but they'll only have our code to do this version of the analysis that we did. So I don't know. Maybe they'll do something completely separate, or maybe they won't do anything at all. I don't know. But that
it's such an important area, sort of heart failure and all the things that you've talked about, and the pilots, the projects. It's such an important area to get right, because it's an increasing area, obviously, with the elderly population getting more and more. So hopefully they do something useful with it and persevere is what I'm thinking, as opposed to start again, and because that's what you want to build on, your findings and your learnings and so on. So, well, thank you ever so much both for going through that with us. It'd be great if there's a report that you could share. I don't know whether anything will be published on the Strategy Unit website, or maybe it's not yet. I imagine it's because I think it's fairly new.
I think there may be a report on NHS Futures. I think that's maybe where it's published, but I'll check with the qual side where it's been published.
Okay, that's great. And I can pass that on, because I think I'd be interested to see actually the qual side as well, because that sort of brings things to life in a very different way, doesn't it? So if I could just invite people just to just look at your screens if you're still around. Oops, I can't operate these two screen things, especially when one's in front of the other. So I just want to mention a couple of things that are coming up in Huddles. My goodness, that's an old photo. Look at Mr. Spilsbury. I mean, and look at Mr. Bourne's hair on that one. Good heavens, I'll have to update that one. Someone, is that Richard? Have you got your hand up? Back to Richard.
So I consider Q&A. I was just going to ask you, being a long time analyst, sometimes you get asked to analyse things where the data's not like captured in the best way to actually do the analysis, isn't it? And then do you try and influence that maybe? I don't know, it's difficult, isn't it? Because you don't know what you're going to get asked to. Try and influence people to better capture data, so it could, in an analysable way, if you know what I mean.
Yeah, I know what you mean. I think the data for these metrics in the minimum data set, most of them are collected for the National Heart Failure Audit. So some of them are for the hospital sites. They are kind of collected in a robust way and can be sort of analysed using more robust methods. But at the community sites, they don't collect data. So for some of them, this may have been the first time this kind of data was collected. So if more kind of like community sites can be included in the National Heart Failure Audit, then I think they could really benefit from being included in including data in like a more robust way and collecting it so that it can be validated and used for an analysis like this.
And to be fair, in this report, I think a lot of the recommendations were literally about, how well, not so much about accessing the data, but just like what data does get included in that audit, because that's where the good data is. So we want, as much as is viable, being collected in that kind of high quality way.
And I'm sure that's one of a very strong recommendation, is to improve data collection. And as we've seen, and as people sort of know over the years, the community services data is typically less robust and collected in different ways. Even though there is a set database, it's collected in different ways by different organisations, and so it needs to improve. So you can get that the measuring the good old left shift, so we can actually monitor the true impact of what's happening with these projects, especially when they are aiming to prevent admissions. It's a very difficult thing to measure if you can't actually measure what's happening on the community side of things. So that's a very good question. Okay, I've just got time just to just tell you what's coming up in the next few huddles. And there's so I'm still waiting actually to this isn't in any particular order actually. So we still want to share with you the new hospital program demand and capacity model. I think you're going to be really interested in that, and it's going to you'll hear about it more and more. But I'd like to share it with you here. We're going to be looking at problem structuring. Problem structuring is really important in everything that we do. Might not call it that, but it's so important in all of our work, and that's with Stephen Wyatt. Janine Della from Leicestershire is going to be talking to us about the impact. They did a study on the impact of having a healthcare plan on spend. So that came up with some interesting results. So again, so relevant. This is looking at particular aspects of care. There we've got Dan Isaac from Exeter Uni. You might remember Dan, who did lots of training, really excellent training with us on data visualization. So he's coming to talk to us about humans, AI, and the importance of data literacy in a couple of huddles time. And then we've got the health economics unit going to be talking to us about models to assess costs and benefits of investing in initiatives to increase HPV vaccination and cervical screening. Weird word. Cervical screening item. It's just maybe chop off the last 4 letters, and then we've got 1 or 2 other huddles being planned at the moment, but with no particular dates. But we are bottom one here. What time is it? Don't know. Must be close to time. Is I'm not really allowed to mention it, but we're building up to Hacker 2025, so I'll tell you a little bit more about that next time. But in the meantime, I would be thanking you very much, Andre and Faizan, for sharing that with us today. Really appreciate your time here today, and thank you everybody for coming. And I'll see y'all again in just a couple of weeks. Okay, bye bye.
Thank you. Bye.